Hello, and welcome to the Sarcoma Foundation of America's panel discussion, New and Promising Therapies in Sarcoma. My name is Dean Freilich, and I'm the Director of Scientific Affairs at SFA. Thank you for taking the time to join us for what promises to be a very informative session. Before we begin, I'd like to briefly go over the format and logistical details of this webinar. I'll be serving as the moderator for today's session. We have two panelists who will discuss the newest in targeted and precision therapies and cell therapies in sarcoma. After their presentations, we will have questions and answers. I will ask the panelists questions submitted by participants. At any time during today's session, you can submit your questions by entering them in the questions field. Our panelists will not be able to answer questions related to your specific medical situation, so please make sure that they are relevant to the topics raised during the session. The information contained in the webinar is intended to be for educational and informational purposes only. It is not a substitute for medical advice from your physician about your specific situation. Today's session is being recorded and a link will be posted to SFA's website. Lastly, as a reminder, participants are muted and questions or comments can be submitted through the webinar's question portal. An important part of our mission at Sarcoma Foundation of America is to provide educational opportunities to help empower the sarcoma community. Now, I would like to introduce our panel members. Dr. Jonathan Trent is the Director of Sarcoma Oncology at Sylvester Comprehensive Cancer Center at the University of Miami. Dr. Trent's research focuses on the discovery and detection of biomarkers for metastasis, progression, and resistance to therapy in gastrointestinal stromal tumor and other sarcomas. Dr. Sandra D'Angelo is an Associate Attending Physician and Research Director in Sarcoma Medical Oncology at Memorial Sloan Kettering Cancer Center. Dr. D'Angelo's research focuses on innovative ways to use the immune system to treat sarcoma. Again, thank you to the panelists for joining us today. I will now hand it off to Dr. Trent, who will provide the first presentation for today. Dr. Trent?
Thank you. Thank you, Dean, and thank you everybody for taking time out of their busy schedule to discuss this important topic in the field of sarcoma. And I'd really like to also thank the Sarcoma Foundation of America for putting together the series in order to allow us to communicate with so many more patients on the latest breakthroughs in the diagnosis and treatment for patients with soft tissue sarcoma. And it's an honor to share the webinar with Dr. D'Angelo. I'll just begin with just a brief overview of what is a sarcoma. So a sarcoma is a type of cancer that's different than carcinoma, only 10 or 15,000 per year in the United States. Number two, they're from the deeper tissues, and the tumors themselves resemble blood vessels, nerves, fatty tissue. And to make it even more complicated, there's around 175 different unique types of cancer, and each one is as different as breast cancer is to colon cancer. So this is a very unique situation in oncology. Another aspect that's different of sarcoma is it's a molecularly driven entity in many situations. There can be any number of sarcomas that have mutations in the DNA such that that mutation or deletion or amplification leads to turning a normal cell to a cancer cell. So for instance, in GIST, we think a mutation in KIT is nearly sufficient to turn that normal cell in the GI tract into the GIST cell. It's certainly a lot more complicated than that, but many cancers clearly take multi-step tumorigenesis and cooperation of multiple genes and pathways to develop a cancer. And so that does in some ways make sarcoma a unique entity, but it also creates a situation where the majority of the bad acting and the bad things the cancers do are caused by one gene mutation. And if that gene mutation if there's a treatment for it, then that might be much more effective than if you have to treat 5 different genes. And so over the last 50 years or so, there's been a lot of new medicines for sarcoma patients. And on the left, you'll see some of the standard chemotherapies that have been developed over the last 50 years, some of them more recently, like eribulin and trabectedin. And then on the right, you can see some of the targeted therapies that have been developed, many of these in the last 20 years or so. And it's very exciting because each one of these can be highly effective against patients' tumors when they have a specific tumor that's driven by a specific mutation. And so we're going to talk a little bit about precision medicine. So precision medicine is really identifying the particular specific molecular event that is important for that tumor cell, the cancer normal cell, to turn into the cancer cell. And this can be important in diagnosis in many sarcoma types. There's types of testing that we do. Some are called next generation sequencing, which is looking at a very large number of genes in the tumor or in the circulating tumor DNA, and which is a type of liquid biopsy. Tumor cells shed DNA from within the tumor into the blood, and this, with modern technology, can be detected and can be used to steer the treatment of patients with sarcomas. And then precision medicine is also critical for treatment. And the last 50, 60 years of research have led us as a community, as a cancer treating community, into a situation where we have the technology to identify specific changes in the tumor that cause that normal cell to turn into the cancer cell. We've also at academic universities like Sylvester and Sloan Kettering and many others, we've been able to identify, we've been able to partner with other academic centers, pharmaceutical companies, to develop medications that can bind to those mutant proteins and essentially turn them off, like turning off a light switch in some situations. So this precision is a new way, relatively new way, that we steer patients to the therapy that's most likely to help them with the fewest side effects. And so we order these tests that we're talking about, next generation, from our electronic medical record in clinic, whether that's circulating tumor DNA or a test on a patient's tumor that was resected years ago. We get those results. We may discuss it at our molecular tumor board. We may see the patient in our precision medicine clinic. We may identify a precision medicine clinical trial for a patient. And then we work together collectively to look at the results in multiple institutions, through multiple people doing this testing, to therapeutic approaches. And so I'll just begin by discussing one tumor where we use precision medicine in many different ways on a day-to-day basis, and that's gastrointestinal stromal tumor. And there's a high frequency of metastatic disease. It's really a situation of a driver mutation, meaning that there's one mutation that's critical, and it's now 5 different medications where we can use these different medicines with varying degrees of success. And it's just an example of the protein from the gene kit. When there's a mutation, it gets activated and drives all of these bad things at the bottom of the screen. And then imatinib can come in and turn that mutant protein off, just like turning off a light switch, and block all of these tumor pathways and kill substantial numbers of tumor cells. In some samples we've looked at, over 99% of the tumor cells are dead after imatinib. But it's the more we study, the more complexity we develop and we identify. And now, in addition to the KIT mutations and the PDGFR mutations, and we know there's a bunch of other driver mutations, some of which we have other therapies for, some of which we're still trying to develop new therapies. Sadly enough, we looked at the National Cancer Database a few years ago, and we found that patients with metastatic GIST or primary GIST who are going to be treated with imatinib, only about 30% undergo KIT mutation testing. 70% of patients are being treated blindly with these medicines, not knowing what the probability is that it's going to help a patient. And this is just really unacceptable. So that's increase awareness about mutation testing for all sarcoma patients. At next generation sequencing and find the mutations that are driving the tumor. And in GIST patients, we usually find a KIT mutation, but we also find PDGF receptor and other mutations. And it's becoming increasingly important to identify also the drivers of resistance. And so in GIST patients in our series, we found that about 60% have a secondary resistance mutation in one specific area called exon 17, while about a third have a resistance mutation in exon 13. And this is becoming increasingly clinically important. And so the reason why we think it's becoming important is because of this histogram we created. And this is based on some of our data, other people's experience, some data from Cesar Serrano and Mike Heinrich, and mostly in vitro data, but some patient-related data. And so mostly from cell lines. And so importantly, what we found is that patients who have an exon 13 resistance mutation, remember this is about a third of the patients, they respond really well to sunitinib. Green is good, okay? Green is good, so they respond very well to sunitinib, but they don't respond to imatinib, they don't respond to regorafenib or the other kinase inhibitors. Conversely, when a patient has an exon 17 resistance mutation, and this is about 60% of GIST patients, that resistance mutation leads to resistance to sunitinib, but sensitivity to all these other kinase inhibitors. So in theory, you would think that it would allow us to identify this resistance mutation and select the optimal treatment for the patient. And in fact, that seems to be turning out to be true. This is just an example of a patient that has a mutation in the liver here by the red arrow in the bottom left. The patient had a great response to imatinib, progressed on imatinib, was placed on a clinical trial with avapritinib. At the same time, we did circulating tumor DNA testing. And what we found on circulating tumor DNA was that she had an exon 13 resistance mutation. Sure enough, at the next scan, we found marked progression of disease, probably 30-fold increase in tumor volume. And so once we identified this exon 13 resistance mutation, we promptly put her on sunitinib, and she had a great response to therapy that's been durable for many years now. And so it's really, it's one example, but it's really proof of principle. Also that exon 9 is treated better with 800 milligram. RAF muted GIST can be treated with RAF inhibitors. PDGFR D842V GIST used to be resistant to everything. Now avapritinib is highly effective. The downward, if the bar is going down, that represents how much tumor is shrinking. And so virtually all of these patients had tumor shrinkage in the the study. And so now for all of the different types of GIST, we can match the best treatment to give them the optimal chance of shrinking their tumors. And this is also becoming true in other sarcoma types. So here's a patient of mine. You can see on the right, there's this subcutaneous mass by the yellow arrow, and it is a dermatofibrosarcoma. Well, this mass was invading the patient's eyelid, was seen out in the community. Patient was recommended to have his eye removed. And so that wasn't acceptable to the patient. We saw him in clinic and recommended trial of imatinib, which is also a PDGF inhibitor. And as it turns out, dermatofibrosarcoma is caused by a translocation involving PDGFB. So this patient had massive regression of the tumor, and at our Bascom Palmer Eye Institute was able to have an orbit sparing surgery. Another example with another translocation between collagen and the colony stimulating factor leads to PVNS, which we now call tenosynovial giant cell tumor. And there's a number of different inhibitors that are out there. Pexidartinib is FDA approved, but there's several others. And again, these are highly effective. The yellow arrow, you see this tumor that essentially nearly goes away after just 8 weeks of therapy. So targeted therapy is very effective. If you, for instance, if you took a non-targeted, non-precision approach and treated a bunch of sarcoma patients with pexidartinib and you didn't select them for this translocation, then it wouldn't be nearly as effective. There's another sarcoma called giant cell tumor of bone that seems to be driven by this protein called RANK. Turns out that there is an osteoporosis drug that is a RANK ligand inhibitor. It binds up the RANK ligand. And this is a patient who presented on 80 or more milligrams of morphine a day, was having difficulty walking, in constant pain. And so we treated her with denosumab. And although you don't see much change in the bone architecture, this older PET scan shows that the black goes away, which represents a substantial response, which was great to see because 2 weeks after treatment, she was walking and was off all pain medicine. So again, understanding the biology, selecting the therapy in a precision medicine approach is highly effective. One of the newer agents approved for sarcoma and other cancers is called larotrectinib, or entrectinib is another one, and they're highly effective when there's a translocation involving NTRK. So this is another gene that makes a mutant protein, and you can see tumors shrink away on therapy in this precision medicine approach. We see a lot of patients with chondrosarcoma and study some of these tumors in the lab, and we found that some chondrosarcomas are caused by a mutation in the normal cell into the cancer cell. And we've worked with partners in the pharmaceutical company to develop inhibitors of mutant IDH, such as ivosidenib, that can be effective in select circumstances at shutting down this pathway, reversing the bad things the tumor are doing back into the normal state. And you can see this patient of mine here. It shows everything here that is white on the left is the tumor. And then even durable, almost 3 years on treatment, you can see that almost all of the white areas are gone. There's little pockets of chondrosarcoma, but almost a complete response to therapy. And this has been durable for many, many more years for this patient, luckily. And then I'd like to really end just by discussing a little bit of the work that the sarcoma community has come together to do for patients with desmoid tumor. So desmoid tumor is it's a sarcoma that doesn't metastasize, but it's locally aggressive. And patients with desmoid tumor can be in a lot of pain, can have disfiguring surgeries. and have limited treatment options. And some of the treatment options have a lot of side effects. So there's interest in developing newer, less toxic therapies, which is really the paradigm of precision oncology. And so SpringWorks and others have developed gamma secretase inhibitors. This one has the lucky name of nirogacestat. And so nirogacestat was studied in a clinical trial of 142 patients, and 71% of the patients were found to have a reduction in the risk of progression. And there was a 41% response rate in patients, many of them heavily pretreated. And in desmoid tumor, we all know that the 41% substantially undermates the patients that benefit. So this is a highly effective drug that we all have our fingers crossed for FDA approval. So I'd like to thank the team, the sarcoma team back at Sylvester, and who really are the ones in the trenches doing our precision medicine and sarcoma work. And thank all of you for taking time out of your busy schedules to join us today to discuss this important topic. And thank the Sarcoma Foundation of America and Dr. D'Angelo for this event. Thank you.
Should I get started or?
Yes, please.
Okay, great. So echo Jonathan's sentiment. Such a pleasure being here today and having the opportunity to share what we've learned so far in the context of immunotherapy and sarcoma. Also would like to thank the SFA and for the invitation and bringing us all together. I think it's a wonderful opportunity to hear what the field has done. So going to get started. I entitled my talk Immunotherapy and Sarcoma, Using the Body to Fight, because essentially that's what we're trying to accomplish in the context of immunotherapy drugs. These are just my disclosures. So I'm actually going to start with a patient of mine. AA is a 54-year-old woman who at age 14 had non-Hodgkin's lymphoma. She received aggressive therapy and developed some complications from those therapies, including challenges with her thyroid as well as her heart. And then she developed breast cancer and a lymphoma, and then ultimately developed a pleomorphic sarcoma. And in 2015, it metastasized to her lung. She initiated some standard chemotherapy that we used in this disease, such as Doxil, but that made her heart function worse. And then she also developed a side effect from the chemotherapy, known as pneumonitis, when you have inflammation of the lung. So at this point in her care, we were sort of at a crossroad. We can think about starting third-line chemotherapy, which was reasonable. And then the other option I offered this patient is sort of thinking outside the box, offering a novel approach and enrolling in a clinical trial. So she actually opted to participate in the clinical trial. In 2013, immunotherapy was deemed to be the breakthrough of the year, given all the advances that had evolved, mostly in other cancer types. A lot of this originated in melanoma, which is clearly not sarcoma, a different disease. But given those breakthroughs, we now know that along with the important topic that was reviewed by Jonathan, precision therapy, traditional chemotherapy, surgery, radiotherapy, immunotherapy forms one of the pillars of cancer care. And each of these pillars are integrated and may be appropriate for patients at different parts of their treatment journey. But the idea of immunotherapy in sarcoma is actually not new. William Coley, one of the so-called fathers of immunotherapy, noticed in 1890 that when a patient with sarcoma developed an infection after surgery, that patient seemed to be less likely to develop metastatic disease. There was something about the immune system fighting the infection that perhaps prevented the sarcoma from coming back. And he ultimately developed Coley's toxin, whereby he injected bacteria. And many of the approaches that he used in research obviously are not the way we would do research today. But his observations were really important ones. And it's interesting that it all originated in sarcoma, a disease that's obviously near and dear to all of us. And so the question I asked is, can we use the immune system to fight sarcoma? And I'm going to talk about two broad topics. One is checkpoint inhibitors. These are drugs called Opdivo or Keytruda. We may see commercials on TV with these types of drugs. And then the second approach is T-cell therapy. In 2013, right when the changes in melanoma were happening, I asked the question, can we do this in sarcoma? Is there any rationale? And so I embarked on this effort to look at some sarcoma tumor tissues and see if these sarcoma tumor tissues had immune cells. And what we found, as you can see in the bottom bar graph, each sarcoma looked a little bit differently. Even within the same types of sarcoma, for example, in the middle, there is some representation of GIST. It's different. The amount of immune cells vary, but there are some immune cells, and so maybe there is some rationale, and that formed the foundation to really embark on this first combination immunotherapy clinical trial. We worked with the Alliance in Clinical Trials Oncology Group and CTEP. They supported this concept, and we were able to treat a number of different sarcoma patients with either nivolumab or nivolumab with ipilimumab. I'm going to go back to my patient who actually embarked on this treatment journey, and she began treatment with the combination in May 2016, and her sarcoma shrunk over time. She completed 2 years of treatment as was designed in the protocol, and her more recent scan, October 1st, 2022, demonstrates that her sarcoma hasn't returned, and she's doing quite well off of all therapy. And to me, this is an example of success. We need more stories like this patient story, obviously. What we learned since then, SARCO-28 was a study of Keytruda, and this was actually the first immunotherapy study ever conducted, and this was the first study really to start to teach us that the one-size-fits-all approach in sarcoma doesn't make sense. And depending on the type of sarcoma, immunotherapy with one drug alone, such as Keytruda, may be beneficial to some patients. And in this study, we began to learn that. So a group of patients that have undifferentiated pleomorphic sarcoma, or UPS, seem to have the highest benefit. Patients with liposarcoma, it was a little bit lost, but there was something there that probably warranted further investigation in the future. And then with the trial, with the combination, what we learned from that trial is that actually adding ipilimumab increased the response rates some, but we always want to balance that with the potential for side effects as well. And so there is a clinical trial ongoing right now looking at a PD-1 inhibitor called envafolimab with or without ipilimumab, specifically in UPS, because that's where much of the promise has been. But we have to, as a lot of these data was actually just presented by Dr. Trent, and what we now know is that the success in sarcoma is actually driven by, first, the underlying sarcoma, and two, the underlying biology. And we need to actually use the same approach as we develop immunotherapy drugs. And what we have now learned is that depending on the type of sarcoma, the responses may or may not be relevant or helpful. So you can see in this bar graph, these are the percentage of patients that responded with a number of different sarcomas. We've also learned that immunotherapy can be beneficial to patients with angiosarcoma, most commonly cutaneous angiosarcoma, when the PD-1 drug is used alone. There was interesting data presented by Dr. Wilkie at our annual sarcoma meeting, CTOS, more recently, which showed that even some other angiosarcoma subtypes can also benefit with some interesting new immunotherapy type drugs. And then ASPS, or alveolar soft part sarcoma, also has shown promising response rates. So depending on the type of sarcoma, using checkpoint inhibition alone may make sense. For the rest, I think that leaves us in a predicament to really explore alternative options, or perhaps use different combination strategies, ideally always in the context of a clinical trial. And so one of the approaches that we've taken as a field now is really to use clinical trials to enroll patients based on the type of sarcoma that they have. When it's safe, it's really helpful to obtain a biopsy to ultimately really try and learn which patients are benefiting and which patients are not benefiting, and what is the next best drug that should be used. And that hopefully will allow us to continue to understand immunotherapy based on the underlying sarcoma and make some impact. So for this section, the checkpoint blockade, we need to take different approaches based on the type of sarcoma. And ultimately, from most sarcomas, there's likely going to be a need to combine different drugs. And what those drugs are and how we combine them, obviously, is an important area of research. And I think the collaborations that we have across both nationally and internationally will allow us to really achieve this goal. So I'm going to shift gears now and talk about a different topic, also immunotherapy, but this is referred to as adoptive cell therapy. Adoptive cell therapy is a way to modify patients' own immune cells and kind of reprogram them to fight tumors. There's a number of different ways this can be done. There's three main strategies. Starting at the bottom, the first is tumor infiltrating lymphocytes. So if you see the figure of the person in the center of the slide, with TIL or TIL therapy, what happens is that a tumor is removed. You remove all the immune cells, what we call the TILs, and then you expand them, and then you give those immune cells back to patients. There's been some work in sarcoma done with this approach. A lot of the advances, again, have been seen in melanoma. The other form of adoptive cell therapy is what we call chimeric antigen receptors. This is what is referred to as CAR therapy. In blood tumors like leukemias and lymphomas, CARs have been FDA approved and really have shown a lot of promise. With CARs, the goal is to target something that's expressed on the surface of the tumor cell. And that's a little bit different than engineered T-cell receptor, because in that setting, you're targeting a protein that's found within the tumor and requires some help from different parts of the immune system to allow that cell to be ultimately recognized. Much of the work and advances in sarcoma have actually occurred with T-cell therapy, with the engineered T-cell receptors. In order to design either a CAR or an engineered T-cell receptor, you need a target. And in sarcoma, our targets have been these proteins called cancer testis antigens. Cancer testis antigens are proteins that can activate the immune system. They actually are not found in normal tissues, and that makes for a good target because that would limit potential side effects. When you look at some of the cancer testis antigens that are overexpressed in sarcoma, some of the more common ones are MAGE-A4 and NY-ESO, and a lot of the work actually has been with those two particular cancer testis antigens. So the way T-cell therapy works, it originates with a patient, obviously, who has had sarcoma that's come back and spread, and oftentimes has received some form of standard chemotherapy. The first part is called pre-screening. The pre-screening, remember I told you that in order for the immune system to recognize this protein, you need to have certain immune cells present to allow you to accomplish that goal. And there's a requirement for a specific type of blood called HLA. So that's the first step. You check to see if you have that HLA. Once we learn that you have that blood type present, you then check the tumor for either of those proteins, depending on the clinical trial, either NY-ESO or MAGE-A4. You then there's a process called leukapheresis, where the blood is removed and then it's sent off to a manufacturing site where the cells are genetically engineered in order to recognize that protein. And once the product is ready, it's sent back to the hospital, the site that's going to be treating the patient. The patients receive lymphodepletion chemotherapy. You receive high-dose chemotherapy in order to eradicate all the immune cells present in the body to make room for these new cells. And then there's infusion of the product, and followed by obviously follow-up and close management for potential side effects. So NY-ESO is highly expressed in two sarcomas, specifically synovial sarcoma and myxoid round cell sarcoma. And these two sarcomas were the ones that have been most studied in the context of T-cell therapy. A lot of this work actually originated in 2011. Dr. Rosenberg at the NIH spearheaded some of the earliest clinical trials and demonstrated that using T-cells can actually shrink synovial sarcoma and can also shrink melanoma. Those were the original trials that really laid the foundation for all of the work that came after. And so one of the initial trials that we became involved with, as well as a number of different centers throughout the United States, as well as in Europe, is this clinical trial with lete-cel, which targets NY-ESO. Sort of went over the process is screening, manufacturing, giving the chemo, giving the T-cells, and then following. Talk a little bit about some of the side effects. Patients are receiving high-dose chemotherapy, so the most common side effects actually are a decrease in blood counts. We also look out for something called cytokine release syndrome, where you can have increased inflammation in the body that can be manifested by fever, difficulty breathing, rapid heart rate. We've learned how to manage these side effects, and we are the teams that now are involved in these types of therapies, which are typically very highly specialized teams, are able to address the side effects, and it's quite safe to receive this therapy. These are waterfall plots and the bars show decreases in the tumors. And you can see across a number of different cohorts of patients, there's been a decrease in the tumors. One of the biggest challenges, though, with this particular approach is that even though the tumors shrink, the duration for how long they shrink for needs to be better. It's not where we want it to be. But this work has formed the foundation for other cell therapies. This particular product was also tested in myxoid round cell liposarcoma, and similar, we see promising results. And then more recently, there's been a lot of work with afami-cel, which is a T-cell receptor that targets a different cancer testis antigen called MAGE-A4. And the approach is, again, very similar to what I've already described with the NY-ESO. You screen for the right blood type, for the right protein. Once you meet those treatment criteria, you undergo leukapheresis, where they remove the immune cells. They genetically engineer and modify them, and then patients receive chemotherapy, followed by the T cells, followed by follow-up. With this particular product, there's been promising response rates with 40% of patients with synovial sarcoma having shrinkage in their tumors, and the duration of response has been for about 50 weeks in synovial sarcoma, a little bit less in round cell sarcoma, where it's about 18 weeks. And 8 responses are ongoing at this time. So this is a very promising approach, and we hope to ultimately see this get FDA approved in the future. So where will the future take us? So in the past, we used to enroll all sarcoma patients into one clinical trial. Right now, I think the approach is more histology based. And depending on the type of sarcoma, you go on the trial that makes sense based on the underlying disease. But will we ever get to a point of precision immunotherapy? Dr. Trent talked about precision medicine, but can we do the same with immunotherapy, where learning and understanding the underlying disease, can that guide how we approach care of patients and the recommendations that we make? So in conclusion, a subset of sarcomas will benefit from checkpoint inhibition alone. These are drugs like Keytruda or Opdivo, and most commonly UPS or ASPS, and some angiosarcomas probably will benefit from checkpoint inhibition alone. But most other sarcomas will require some kind of combinatorial strategies or some other alternative approach. Much of the breakthroughs with T-cell therapy have really happened in the context of cancer testis antigen. This is a very promising approach, but for a very small select group of sarcoma patients. So we need to do more to expand the applicability of this technology. We need to identify different targets and define different approaches. But I think what's amazing is that it really demonstrates the feasibility, the safety, and the collaboration across a number of different national and international centers to really get these clinical trials done so that we can ultimately get these drugs approved for our patients. Enrolling in clinical trials, I think, is a very important thing that ultimately allows us to expand our treatment options and offers new and novel and promising approaches. And I'll just conclude by saying thanks again to come to this webinar, providing the opportunity to share this update. It's been great, and thanks to Dr. Trent as well for being a part of this.
Thank you, Dr. D'Angelo and Dr. Trent. We have a few questions for you both. First question, it looks like it's more geared towards Dr. Trent. So does chemotherapy change the genetic makeup of tumors such that baseline tumor genetic findings would differ in a meaningful way from tumor genetics tested after chemo? Oh, you're on mute.
It's possible. It's generally not the case in terms of precision medicine. If a tumor has TRK and it's treated with, and the patient is treated with chemotherapy, TRK usually remains the main driver mutation, sometimes in the setting of resistance mutations within the same gene. So it's not generally the case in precision medicine. Interestingly, there might be more changes relative to immunotherapy than with targeted therapy in terms of evolution after chemotherapy and radiation. I don't know what maybe Dr. D'Angelo thinks.
Yeah, it's a great question. I think there's actually data in other cancers that using immunotherapy after chemotherapy can make the immunotherapy less effective. The best example of that is actually in Merkel cell carcinoma. In sarcoma, we don't know is the short answer, but and immunotherapy is obviously not FDA approved, so it's a little bit more challenging for us to deviate from what we think is a standard approach and just go straight to immunotherapy. However, I think there are ways that can be done, and again, I think if that's something of interest, thinking about clinical trials that allow that to happen, I think is a good way to explore this. There's also some interesting clinical trials that are ongoing in a number of different sarcomas, combining chemo with immunotherapy as well. And so while we think that chemo can make things worse, we actually have learned in other cancers like breast cancer and lung cancer and bladder cancer that combining immunotherapy with chemotherapy can actually make each of those therapies more effective. So it seems like we really don't know the answer. And I think that, again, when we ask these questions as a community, it allows us to really formulate the answers in an evidence-based fashion.
I'd like to follow up on that. What about radiation therapy following with immunotherapy? Have you seen anything?
Yeah, it's the
efficacy
same
there.
Yeah, it's also a good question. A lot of this work has happened in other different diseases. There's actually a clinical trial right now through SARC, which is one of our sarcoma cooperative groups that is combining Keytruda with radiation with or without Keytruda to ask that very question. And in the general field of immuno-oncology, it's sort of a mixed bag whether radiation helps or not make immunotherapy more effective. So we don't know the answer, and the field's a little bit divided from that regard.
So next question is, how does a patient get the testing, and how would you recommend identifying therapies based on testing? I guess this would be applicable to both of you.
Yeah, I would just quickly say that the testing is done either on the tumor or on circulating tumor DNA at the time when there's really approaching no great other treatment options.
Do you have any thoughts on that, Dr. D'Angelo?
Yeah, no, I think exactly what was said. I agree with that. I don't think there's much else to add.
And then what if you have no tumor biopsy left for genetic testing? So there's maybe some circulating tumor DNA, but what else would you say with
Well,
that?
if there's no tumor left on imaging, that's a very, very good thing. So number one, that's great news. And I would just encourage diligent screening, usually through radiographic imaging, to detect it early if it does come back. And, even after 5 years, we generally recommend some interval of continued imaging. We've all seen patients who stop after 5 years and at 7 years get a recurrence. So we don't want to see that. We want to catch it early. And so we recommend imaging. And at the time of imaging, if there's tumor to biopsy, it can be biopsied for NGS. And the technology is always evolving. So if you don't have any visible cancer in your body right now by imaging, I don't think I would recommend NGS testing unless you were thinking about some type of treatment, because the NGS and the mutation testing technology is going to be better in a few months and a few years. And so unless there's other concerns.
Nice. Hey, make sure you get that.
Okay, next, do either of you have any thoughts on the new research out of Cedars-Sinai this August, where they found that in many sarcomas, myeloid immune cells produce a protein called macrophage migration inhibitory factor, or MIF, and that protein was causing the immune cells to promote tumor growth rather than to stop it? Is this like in a likely area for targeted inhibitors in the future, or T-cell therapy?
Yeah, so I think that's an interesting question. We know that the immune system is actually really complicated. There's some immune cells which we think are good to shrink tumors, and then there's a lot of things within the tumor and where it is that can actually make tumors grow. There's been a lot of work done and published noting that some immune cells like macrophages or myeloid cells or tumor-associated macrophages or myeloid-derived tumor cells, all within that family of immune cells, can actually make the sarcoma grow. And there's been a number of attempts to try and eradicate those bad immune cells with some drugs. So far, not yet successful. And I think that there's a lot of interest in that field and really figuring out the right way to do it. I just don't think there's a lot of drugs that can eradicate all those bad immune cells effectively. The best example of that right now is actually a clinical trial in leiomyosarcoma, where doxorubicin is being combined with a drug that is supposed to eradicate some of those macrophages. So that's a promising study and approach that we don't know whether it will work or not, but a big area of research.
Thank you. So the next question is, it appears that current T-cell therapy is more or less for 2 subtypes. Is there any encouraging future for the other subtypes of sarcoma?
Yeah, that's such an important point. Well, we look at this work and just these 2 sarcoma subtypes as what we hope is just a foundation to do more and learn more. And yeah, there are other trials that are ongoing. So the T-cell therapy in those 2 specific subtypes are targeting the proteins that are found within the center of the cells, right? There's other work that's ongoing targeting the surface of the protein. And there's a lot of proteins that are expressed in sarcomas that are actually expressed in other different cancers. And some of this work has been published with different targets called GD2 or GD3. So the short answer is yes. I think the future is bright. I think that this work does take a lot of time. And but I do think that this will be more, there'll be more of this to come in the future.
Thank you very much. So one viewer has read some studies that research teams have looked at sarcoma in metastatic patients, stage 4 and local therapy. And then mostly starts with chemotherapy, and then the team looks at targeted therapy afterwards. When patients reduce from stage 4 to stage 1 and the cancer becomes more localized, what have researchers found with picking targeted therapy in that context?
I think that there's a lot to say about that question. That's a very good question. But we do see patients sometimes whose metastatic sites just disappear on chemotherapy. And so we approach those patients with curative intent. We treat them with chemotherapy. We do radiation therapy to the primary for types where you use radiation, like let's say an extremity leiomyosarcoma. We would do preoperative radiation, we would do resection, and depending on the results of preoperative chemotherapy, we might give postoperative chemotherapy as well, with the intent of giving the patient the best chance of being cured. Now, several of the questions in chat have discussed maintenance therapy. And it is, it is done sometimes. Some people do it, some people don't, but I would just caution everyone that there's not really any evidence, for instance, for a leiomyosarcoma after chemo, after radiation, after surgery, to put that patient on maintenance pazopanib or maintenance trabectedin. It's compelling, and it might make you feel good to do it, but there's just very little data to support that approach.
Thank you very much. The next question is, how can patients access these treatments and trials? Does it have to be submitted by your main oncologist? And how do you approach it if your oncologist won't help you in the process to get onto a clinical trial? And maybe you could go just very briefly into the process of enrolling.
Well, I could say a little bit about the precision medicine trials, and I think it's a lot of it's the relationship you have with your oncologist, and as long as they're looking for trials for you, if you need a trial, as long as they're looking and they're not finding any, then maybe there just isn't any. But they should certainly be looking for trials if there's a patient who needs a clinical trial, because as Dr. D'Angelo stated earlier, the best patient care is on a clinical trial.
Thank you very much. It looks like Dr. D'Angelo had to drop off here. Let's see if there's another question. Can you see a role in the future for CRISPR-Cas9 and other gene engineering techniques in the treatment of sarcoma?
Absolutely. It would be fabulous if we could pull that off. Definitely.
Excellent. I think that pretty much wraps it up. That looks like Dr. D'Angelo is coming back on. But so I think that there was one more question for her, if she's able to come back on real
Sorry,
quickly.
I got kicked.
Not a problem.
Yeah, for some reason I got kicked off the Zoom, and I can't turn my video back on now, but I'm here.
I think that'll be fine. Thank you very much.
Perfect.
There you are.
There you go.
So with regard to immunotherapies, will patients be expected to use immunotherapy as maintenance for the rest of their lives, or how does that work?
No, we don't even know if immunotherapy is effective for most sarcoma subtypes right now. The question of maintenance, again, has been best proven in I think in bladder cancer, actually, where patients receive standard care chemo followed by immunotherapy, and then they stay on it for some period of time. So I would not recommend maintenance.
Oh, looks like her connection is poor. I think though, with that, we'll end the session.
In your care, and we as a sarcoma community often will actually work with because all my New York patients like to leave New York in the winter time. So seeking, you know, opinions in sarcoma centers, I think will ensure that good decisions are made.
Excellent. Thank you very much. And I think with that, we'll have to wrap up our session. Thank you again, Dr. Trent and Dr. D'Angelo. We appreciate the time that you've taken to be with us today and sharing your thoughts and your expertise. We appreciate all that you do for the sarcoma community. And thank you everyone who tuned in today to be part of the discussion. As a reminder, today's session was recorded and a link will be posted at SFA's website within the next few days. You can find us online at www.curesarcoma.org. We have also posted information for future education sessions on our website. This now concludes the discussion. Thank you, everyone.
Thank you.
Right? But she said that at the party,